Namaste viewers, welcome to the Facebook live session. Today our topic for discussion is can bone marrow transplant completely cure leukemia? And for our discussion we have with us Dr. Padmaja Lokireddy, Senior Consultant Haemato Oncology and Bone Marrow Transplant at Apollo Cancer Center, Apollo Hospital, Jubilee Hills, Hyderabad. Welcome doctor to our Facebook live session. Starting with our first question, what is leukemia and what are the types of leukemia?
So, leukemia meaning it is a blood cancer. There is a cancer inside the blood which is visible. So, these leukemias come from the bone marrow. Bone marrow is a factory which produces cells. Those are red cells, white cells and platelets. There are different types of leukemias. There are some called acute leukemias, there are some called chronic leukemias. Acute meaning to say they have come on very quick in the last 3 to 4 weeks, not more than 3 months duration. Chronic leukemias are slow growing, lingering, they are there for a longer time. In general, acute leukemias are more dangerous because they grow very fast and they cause more problems. Chronic leukemias are not so problematic in terms of life risk. They grow very slowly, so they allow time to treat those cancers. In general, as they grow very fast in acute leukemias, the treatment also very intense, and we tend to cure them pretty quickly. In chronic leukemias, as you know that they are slow growing, your treatments are also very slow. Most of the times it's tablets, maybe immunotherapy, and they tend to not to be curative. You would get them into remission and you would have a longer time. So, in one way of looking at it is acute ones you can cure them easily. Chronic ones you can treat them and get them into remission and keep the life going.
Thank you, doctor. Coming to our next question, how patients are diagnosed with leukemia? What do they present with?
Okay. So, in other words, you're asking how do the patients of leukemia come to us? So, there are different ways how the patients present to us. There's some who could just have had low blood counts. So, why did they do the blood test? They felt very tired, feeling short of breath. They're not able to do their daily activities, feeling run down. So, they went for a blood test, and the blood test showed a low hemoglobin, low platelets or a low white cell count, or some type of white cells are very high. These are abnormalities in the blood test they found when they did the test for tiredness or breathing difficulty. One set comes like this. The second set comes where they had an infection, they're not getting better, they went to the doctor, they've had some antibiotics, not improving, they had blood tests, and the blood test showed an abnormality. Henceforth, they started investigations for low platelets or a low hemoglobin, they come to the diagnosis. A third set of patients who have been admitted where they're not well, and then they found the white cell counts are very high. Initially they were okay, but they started going up abnormally, and then you start investigating, then you may find this problem. And in these similar group of patients, they may have presented to a cardiologist because they had a chest discomfort and they thought ECG is showing abnormalities, but as a matter of fact their hemoglobin is very low at 3 or 4, that's what is causing the cardiac symptoms. When we start investigating the anemia, you get the diagnosis. Or in some times where patients have presented with a kidney problem and low hemoglobin, when you start looking at why the kidney has failed, there is a link to the hemoglobin and you get a diagnosis. Or there are times when people had a liver problem, they come to the emergency with some other things and they also had a low hemoglobin, they're breaking down the cells and they may have lumps somewhere else. They had a scan which showed a lymph nodes, they had enlargement of spleen or liver. That's the time when you start worrying that this could be a cancer, a blood related cancer, could be a leukemia or lymphoma. That's how patients present to us.
What are the causes of leukemia?
What causes blood cancer? Most of the times there's nothing we could have done to prevent it. There is no obvious cause in most of the patients who come to us. It is not hereditary, they're not born with any genetic defects, but there are a lot of acute acquired mutations. That means during their lifetime they've got some genetic change which has triggered this cancer cell growth. So, we talk about a lot of environmental agents which could have precipitated a cancer, like people who had radiation exposure for a prolonged periods, or who are working in chemical factories, dye industry, or people who handle a lot of petroleum products, they should wear gloves, and pesticides, farmers who are handling things, they should make sure that they have not had exposure. These are certainly exposure over a long period of times can trigger some mutations, and it's not just all the time there's one change. There is a recurrent changes which happen before the cancers come out. So it's important to prevent having any of these environmental agents which could add up to the risk.
Thank you, doctor.
Thank you.
Next question. What are the treatment options for leukemia?
So the treatment options, if we look at, the treatment will depend on what type of cancer we've got. Is it an acute cancer, that is AML or ALL, or a CML or CLL? But by and large, in blood related cancers, the treatment is by chemotherapy. Either it is an intravenous form or it's a tablet form. Generally, we don't go for a surgical option, and radiation is least needed in leukemia patients. Very rarely we use radiotherapy in those patients who are going for a bone marrow transplant or certain other conditions. But by and large, the first line treatment is always chemotherapy. In acute blood cancers, the treatment is called induction chemotherapy, where you give big doses of chemotherapy, where you want to induce them to get into a complete remission. So when 1 month, end of 1 month, we want to see that there is no blood cancer noted in any of the tests available, but it doesn't mean that they're cured. We call the word remission. That means that we are not able to see the cancer in any of the tests, and the means what we have. That could be a blood test, it could be a bone marrow test, or a scans. But we still need to give more chemotherapy to treat the disease which are not visible, what we call as a minimal residual disease. So we have standard in acute myeloid leukemia, you have one block, you get the bone marrow after 1 month. If they're in remission, you have 3 more blocks of the treatment. So if they've not had a remission, you may change the treatment. Whenever you have to change the treatment, you call them a high risk. That means the first line of treatment, it has not worked for them. You have to change the treatment. So those are the patients you have to think about. How do we prevent the disease coming back? What are the means to do that? That could be a way by doing a bone marrow transplant. In ALL, it's again the same, first 1 month treatment. Most of the times in acute leukemias, patients are inpatient for about a month. And those 1 month is the most difficult period of the leukemia treatment. Patients sometimes feel that they walk into hospital being relatively well, and after the treatment they feel poorly before they get better. So there is an increased risk of infections and different other side effects during the treatment, and one has to treat all these while going through this treatment. Yes, it does appear very vigorous in the first 1 month of leukemia treatment, but that is needed to get the long-term benefits, to get the disease into a deeper remission and to prevent it coming back. And in chronic leukemias, the treatment like CML, it's usually a tablet form. There are different types of tablets called imatinib, dasatinib, bosutinib. There are different lines of therapies, but they're all tablets usually taken, orally and once a day or twice a day, depending upon the tablet what we use. In chronic lymphoid leukemias, that's called CLL, it's common in a slightly older population. There the white cells are high, the lymphocytes are high. They generally go on either just the tablet called ibrutinib or acalabrutinib, or we may add up with the rituximab immunotherapy. So their chronic leukemia treatments are generally gentle. Most of them are on outpatient based. They are very tolerable. Just because you are elderly doesn't mean that you can't take the treatment. These are tablet form of treatment. So don't be, don't get put off by the word of leukemia. In chronic leukemias, it's very well treatable and people can have a long-term outcomes.
What is the role of bone marrow transplant in treating leukemia?
Role of bone marrow transplant in treating leukemia. So again, we talk about bone marrow transplant in patients who have got a high risk. What do you mean by high risk? The patient has got a blood cancer, and we know that this blood cancer, whatever they have got, there is a high chance that this is going to come back after the first treatment. That is what we call as a high risk for the disease to relapse. Those are the patients we pick for a transplant. So how do we know that they are high risk? is the patient who has got a very high blood counts to start with at the time of diagnosis. Suppose their white cell count is more than 50,000, or they've had unusual presentations. They had a brain disease, or they had outside the bone marrow there is a leukemia, or those patients who had first 1 month treatment who didn't respond as well, they still had some left behind. So that left behind disease could be about 4, 5% or 8%, still it is not good enough. We take them through bone marrow transplant after getting their disease under control to prevent it coming back. So those are the patients get the most benefit from transplant. Suppose in acute myeloid leukemia, we categorize patients as a low risk, intermediate risk and high risk. When we say high risk, there is a high chance the disease will come back. And if you don't transplant them, if you give only chemotherapy, after 5 years, there are only 20 patients out of 100 patients are surviving. That means a lot of them we are losing because the disease is coming back again. In patients who are a good risk, that means that 80% of them are doing well. That is, if you treat 100 patients with chemotherapy, 80 of them are doing well at 5 years. Only 20% of patients you are losing. So those patients we don't need a transplant. The ones who are bad risk groups who needs a transplant to prevent it coming back. So what do we do by doing a transplant? The survival of 20%, we make them 60, 70%. You can never make it 100%. There are always ifs and buts, risks and benefits. It has to be balanced as an individual care for that given patient according to their risk stratification of the disease and also patient. How bad the patient can, his clinical condition is, has he got other medical problems, can they tolerate? There are lots of other things which has to be taken into consideration before we think about a transplant and taking the patient through transplant.
Do leukemia grow back after transplant?
So we're just talking about, yes, transplant is the means of increasing their survival chance. You can never say 100% patients could be cured because there is a small chance the disease could come back after the transplant. There are ways and means how we want to optimize this treatment. So suppose if we take the patient to transplant without a deeper remission, there is a high chance the disease could come back. So what we tend to do is we give more therapies to get the patient into a deeper remission and we transplant them. And sometimes when the patient is young, we may want to give intensive transplant rather than a less intensive transplant. And in patients who are after the transplant, we stop immunosuppression much quicker, or sometimes we give the donor, again the same donor, we take some T cells and give it to the patient to boost the patient's immune system to fight the cancer. So there are ways you can do before and after to optimize the care, but still you cannot make it 100%. The outcomes are variable according to the individual's disease type and their risk factors and how they've gone into transplant, what is their post-transplant outcome.
Thank you, doctor. Doctor, can you please list some during transplant and post-transplant complications?
So we just spoke about a transplant is a potential cure for many patients with leukemia. These, like patients when they go through transplant, there are various risks they have to go through. We do something called a pre-transplant assessment of that patient to look at the safety of the transplant. How are their lungs, how are their kidneys, how their disease has been, have they got a good deeper remission of the disease, that is we have removed the disease quite significantly before the transplant. And all these are safety checks which we do. Once a patient goes through transplant, we give chemotherapy so they can get infections, mainly the bacterial, fungal, all these. Or because if it's an auto transplant, there are not big risks. They improve the counts and they get out of the hospital. If it's an allogenic transplant, that is, there is a different donor, there is always this risk about rejection. That's called graft versus host disease. How do we, there are different ways how we reduce the risk by giving immunosuppressants. So during the transplant, you have risk of infections, you have risk of mucositis where patients could have a lot of vomitings, diarrhea. We do a lot of measures to prevent it and treat it as it comes. And disturbances with the salts like low sodiums, low magnesiums, low potassiums that have to be corrected quite regularly. And giving blood products, platelets, all these are part and parcel of transplant until their blood counts recover. Apart from these, They could have organ dysfunctions, the liver and kidney, because you've given a lot of toxic medicines. They have to be monitored carefully. And once they get out of the hospital, that means the blood counts have recovered, the donor has taken in. It's still not that you can ease off. You still need to come for a regular follow-ups at least twice a week to look for any infection, how is the graft doing, and also to see that there is no viral infection. So once you cross 100 days, if you think about a step ladder, so once you finish the transplant, you're outside the hospital, you've done 50-60% of the transplant. But after that, each step going further, you have to make sure you pass the 100 days and then about 6 months until the graft is more strong enough to prevent any viral infections or any other infections can disturb the graft. And the big problem is the GVHD, graft versus host disease, and we have to recognize it much early to fix the problems. In transplant, the key thing is identifying problems much early or anticipating it to prevent it. So despite doing these things could happen, because you can never say 100% safe, but you can optimize these things by looking at each patient as an individual to see what are their risks and optimize the care.
Coming towards our last question, Doctor, could you please tell our audience about the facilities provided at Apollo Cancer Center, Apollo Hospital, Jubilee Hills, Hyderabad?
So first of all, I would like to say Apollo Cancer Center, Jubilee Hills, we've been doing transplants since 2010. So we're mature enough for more than 10 years. Any center which are mature for a longer periods, they tend to have more standardized processes to optimize the care. And second thing, we have an inbuilt HLA lab within the Jubilee Hills facility. So if I want to look at the donor, within 48 hours, we've got the donor HLA typing done. So the results are much quicker. We've got a stem cell laboratory in-house, and we've got a blood bank on site. We've got a flow cytometry results on site. So all these are key things which are important for the transplant process. We've got an internationally qualified transplant consultant team, and we've got a specialist nurses who are trained with us for more than 7 to 8 years, who know the protocols, who work along with the patient, including a class 4 staff who have been with us for a longer time. They are very important because the infections, how they have to tackle each and everything, and how we clean up the processes is also important. Last but not least, the facility where we have a HEPA filtration, laminar airflow, positive pressure maintenance, and a regular check of the bacteria before the patient put on the transplant unit. We have to get that particular room, all the blood cultures negative. We put the agar plates to see that there are no cultures. The water is tested for that there is no infection. And in the transplant unit, suppose if you're not using a particular room, every third day we have to open the taps and run the water to prevent any water stagnation and risk of infection. So there are multiple ways you take measures to prevent any infection. And last but not least, having a regular follow-up and having a coordinated approach between the nursing team, a medical team, and the laboratory staff to get the best outcomes. And one thing I want to say, in Jubilee Apollo, we have got a facility called ECP, that extracorporeal photopheresis. When the patients develop complications like graft versus host disease, we can deal with first line as a steroids and some medications. Sometimes we need a procedure called extracorporeal photopheresis, where we need to remove the blood and take out, kill some T cells and give it back to them. And we have the ECP facility available. During the transplant, we give total body irradiation, we have tomotherapy available. So we've got most of the things in-house. So we're well equipped and designed for continuing this process. We've done multiple transplant for various conditions, right from autologous transplant to sibling allogenic transplant to unrelated transplants, be it from the Indian registry or German registry. And we've got an increasing number of half-match transplant in pediatric group and in adult group. And we've gone up to the highest age group of a patient with a transplant at 70 years, and the lowest being 2 years. So we are catering different age groups with multiple complications. I'm very pleased to be working with Apollo Jubilee Hills for having this facility to excel. The care which I've learned as an international UK, we can implement almost the care what is available in Western country we can implement here at a much faster pace. Thank you.
Dear viewers, we have come to the end of our session and hope we have covered all the aspects. If you still have more doubts, you can book an appointment with Dr. Padmaja Lokireddy and clarify your doubts. Thank you, Doctor, for educating our audience in today's session. Thank you for joining us. Stay tuned for more such educative live sessions. Namaste.